Hi everyone, this is Professor Nicholson lecturing on Apply the Nursing Process when caring for the infant in the first 2 hours of life. Please review the following subcompetencies on your own. Physiologic transitioning. This is a newborn's intrauterine to extrauterine transition. It's critical and a period of adaptability. The circulatory system, respiratory system, and thermoregulation process are greatly impacted during this period. Cardiovascular adaptations. After a newborn is born and separated from the placenta, major changes occur as the newborn transitions from fetal circulation to newborn circulation. While in utero, meaning within the uterus, blood oxygenation occurs in the placenta as opposed to the lungs, relying on the umbilical veins to carry oxygenated blood to the fetus. There are 3 structures that are found in fetal circulation. The first is the ductus venosus. This allows blood from the umbilical veins to bypass the liver and merge with the vena cava. The maternal liver performs filtration at this time. Then you have the foramen ovale. This allows the majority of blood to travel from the right to the left atrium, bypassing pulmonary circulation. Some blood still enters pulmonary circulation, but only to perfuse the pulmonary structures of the fetus. You also have the ductus arteriosus. This connects the pulmonary artery to the aorta in order for blood to bypass pulmonary circulation. Continuing on with cardiovascular adaptations, changes in the newborn circulation occur immediately as the fetus separates from the placenta. The umbilical cord is clamped. Sometimes there is delayed clamping. That's pretty much standard practice at this point. The first breath is taken, and the lungs begin to function, and pressure changes occur in the cardiovascular system. These actions lead to the closing of the foramen ovale. The ductus arteriosus closes within the first few hours following birth, and the ductus venus closes within a few days. They eventually form into non-functional ligaments along with the umbilical vessels. So, if you think about it, the first 24 hours of the newborn's life is a period of transitioning to the world. This is a great visual to compare fetal circulation to the post-transition circulation, so after the newborn is born and transitions to that extrauterine life. You do need to know about the ductus arteriosus. So remember in the last slide, the ductus arteriosus closes within the first 2 hours after birth. What you do need to know is that it directs blood away from the lungs. Notice here in the post-transition circulation, it's closed off. Respiratory adaptations. Following delivery, gas exchange is transferred from the placenta to the lungs. The newborn inhales and begins expansion of the lungs. Surfactant is a surface tension reducing lipoprotein found in a newborn's lungs. It prevents alveolar collapse by the surface tension, and it provides the lungs with stability needed for gas exchange. Respiratory adaptations continued on. A newborn's lungs are fluid-filled while in utero, so in the uterus. Passage through the birth canal, which compresses the thorax, eliminates 2/3 of fluid in the lungs. I always tell my patients, if they have a vaginal delivery, it's a nice squeeze while the baby's coming out. However, those newborns that are born via C-section, they do have a little bit more of a risk of having a little bit more mucus. So they're a little bit more gunkier than the vaginal deliveries because they don't get that same squeeze through as they would through the birth canal. Moving on, pulmonary capillaries and lymphatics remove the remaining fluid. Sorry, there's a typo right there. Factors such as temperature change, pressure changes, and touch stimulate the first breath. So you will see when a newborn is born, a strong cry is a first sign that a newborn has expanded his or her lungs. When born, you'll notice the nurses rubbing on the baby, drying the baby, maybe doing a little bit of bulb suction, but that's not very typical anymore. It really is dependent on the situation. Thermoregulation. Maintaining a stable body temperature is extremely important for a newborn adapting to extrauterine life. So like the last slide, how I mentioned you're, wiping the baby down, that's helping the baby stay warm. Newborns are vulnerable to both underheating and overheating. For instance, if a formerly been stable newborn is noted to have nasal flaring, a fast respiratory rate, and mottled skin, what should the nurse do first? The nurse should check the newborn's temperature. This could be a sign of decreased temperature. Think about it. The newborn has a fast respiratory rate, and that more than likely means he or she is working hard to build a stable temperature. They're not used to doing that on their own. Thermoregulation continued. There are 4 ways newborns transfer heat. The first is by conduction. This is a transfer of heat from one object to another when in direct contact. Heat loss is experienced when the newborn is placed on a cold surface or touched with cold hands. This can be prevented by using warmed blankets and placing the infant skin to skin. I do always like to add, you need to keep in mind what the mother's temperature is. If the mother is super cold, maybe she's in the operating room having a C-section, put warm blankets over them. Keep them both warm together. If a mother has a vaginal delivery and is super hot and sweaty, keep that in mind too. That can also increase the newborn's temperature. Convection. Transfer of heat from cooler surrounding air. Heat loss is experienced by there being a breeze or a cool oxygen flowing. This can be prevented by utilizing an isolette when transferring a newborn and using warm humidified oxygen when needed. Evaporation. This is a transfer of heat through the vaporization of liquid. Heat loss is experienced through amniotic fluid, a bath, or sweating. This can be prevented by drying the newborn thoroughly after delivery, as I've mentioned. Side note, for those that want to be in a NICU eventually, keep in mind if you have a very premature baby, we do not dry them after delivery. They get placed in a little plastic bag because that amniotic fluid helps keep them warm. You don't need to know that, but I do like to add that because if you do decide to get into this field, that is something imperative to know. Radiation. Transfer of heat to cold surfaces in proximity, but not direct contact. Heat loss can be experienced by being placed near a cool window. This can be prevented by placing a newborn away from windows and air conditioners. So note, if you roll a baby's crib in the room underneath of a air conditioner or something with air coming down, that can cause heat loss. So just be aware of where you are placing that newborn and the room temperature as well. Characteristics that newborns have that impact their thermoregulation include: think skin with blood vessels close to the surface. Their increased skin permeability to water. Their lack of shivering ability. They can't really do this until 3 months of age. Limited stores of fat and glucose. Limited movement to produce heat. Their large surface area to body ratio. Their lack of subcutaneous fat. They don't have the ability to adjust their own clothing or blankets. They have an inability to communicate. These little newborns are very vulnerable. You do need to know, moving forward, the 4 ways a newborn can transfer heat and what those nursing interventions include. Again, you need to know the 4 ways a newborn can transfer heat and what those nursing interventions include. It's important to maintain standard precautions when caring for a newborn. During delivery and the initial newborn assessment, there is a high chance of exposure to blood and amniotic fluid. Always don the appropriate PPE, so gloves, goggles, gown. You will notice not everybody wears these out in the labor and delivery world, but it's important that you all do. There is nothing worse than being splashed and soaked in amniotic fluid. It is typically standard to wear gloves when handling a newborn until their first bath. You all need to wear gloves when handling a newborn until their first bath. You need to have very good hand hygiene too. Wear gloves when administering newborn medications, and wear gloves when handling breast milk. Even if you come across donor milk, please wear gloves. Just a little fun fact before I start this slide. Virginia Apgar was an obstetrical anesthesiologist who was born in 1909 and passed away in 1974. She's best known for developing the Apgar score. It's a system used worldwide for evaluating the physical conditions of newborns at birth. So if you also notice, Apgar, her last name, it's a mnemonic too. So A means activity, so the newborn's muscle tone. P is pulse. G is grimace. This one can be a little bit complex to understand at first, but this is the reflex irritability. So is the newborn floppy when they're born? Do they have a minimal response to stimulation, or do they have a prompt response when you touch them? Appearance is their skin color. 0 points, blue, pale. 1 point would be that acrocyanosis, so a pink body and blue extremities. And then pink would be the highest points. And then you also got respirations. Apgar scoring is utilized to determine how effectively a newborn is adapting to that extrauterine life. A score is given at 1 minute and 5 minutes. It's only given at 10 minutes if the 5-minute score is less than 7. Just to give you a little bit information, depending on the facility you are at, if there is a time where they need to do neonatal resuscitation, there are different types of bag masks for this. So just keep this in mind. I'm personally familiar with the AMBU and the T-piece resuscitator, such as the NeoPuff. My facility leans more towards the T-piece. You do not need to know how to use all of these at this level, but please just understand why and how these are used. As RNs working with newborns, NRP is a requirement. So just understand this when you're watching these measures in your labor observations. Pulse check. Let's say you are the baby backup nurse. An expected role is the preparation of the newborn warmer for delivery and ensuring all equipment is available and functioning. So, what preparatory action is the highest priority, especially if you are anticipating the birth of a newborn with a low APGAR score? If you get the opportunity to watch a nurse do his or her checks, please watch. Think. This is a position where multitasking skills come in handy. However, your mind should go straight towards ensuring the oxygen source, such as the AMBU bag or T-piece, is available and correctly attached to the oxygen source. You do not want to be fumbling with this as the newborn is delivered and brought to the warmer. This is a vital part of neonatal resuscitation practices. If you ever anticipate a rough delivery, request the NICU and/or PD provider to be at the delivery. Many hands are needed during a newborn resuscitation, and minutes can feel like hours. This is just a visual so that you understand an AMBU bag, which is right here, versus a NeoPuff. Like I said, not pieces. You don't need to understand how to use this. Just understand this is something that you're going to see when you're at the deliveries. Measurements. Standard practice is to check the length, head circumference, and weight when the baby is born, but this isn't always right away. This could be after a few hours. We love to make sure the newborn is skin to skin with the mother. It's the best place for the newborn, and it's a great way to initiate breastfeeding if that is how they choose to feed their baby. Regarding the weight, just know that a full-term baby is typically 2,500 to 4,000 grams. We like to measure babies in grams. SGA means small for gestational age, AGA means average for gestational age, and LGA means large for gestational age. I'm not going to go in depth with these. All you need to know is that at some facilities, they have different protocols. If there's an SGA or an LGA baby, they more than likely are going to require blood sugar checks with feedings. Regarding vital signs, you need to know, regarding temperature, anything under 97.7 may require a blood sugar check. So why do you ask? Because low temperatures coincide with low blood sugars. Think about it. The newborn is working so hard to keep their temperature up. That's going to drop their blood sugar. Regarding blood pressure, it is not a routine vital sign for newborns. We're not popping blood pressure cuffs on newborns. Most facilities discontinued this practice even. We used to check them right before discharge. But now it really just depends on a provider order. In all honesty, the only time I'm checking blood pressures is I'm doing 4-point blood pressures on all limbs if there's a heart murmur and the provider orders it. Please review this graph and just understand the ranges for vital signs. Notice how it varies in comparison to an adult. Baby heart rates are very hard to auscultate. Airway management. So this is at delivery. So afterward, you'll notice a lot of nurses immediately wiping the nose and the mouth of the newborn to clear secretion. Sometimes suction is necessary, sometimes it's not. And you mainly would do this with a bulb syringe. The steps to use a bulb syringe correctly. First off, make sure you always start with the mouth before you go to the nose. Think about it. If you go straight to the nose first and you suction it out secretions, those could get trapped in the back because it would get pulled from the mouth. So now you get secretions trapped in the back. So clear the mouth before you do the nose. Don't bring it up and about. You want to stabilize the newborn's head, sometimes having the head lower than the body to help with the secretions. Turn head to the side and compress the bulb. Insert the bulb into the cheek and release. Do the same steps for each nostril. Make sure you clean that out very good. I would probably not use the same one for a long time. I'm sure you all have seen videos of what it looks like inside of a bulb syringe if you don't properly clean it and use the same one for a long time. What you do need to know moving forward: an independent nursing action that can stimulate respirations at birth. It's easy. You just vigorously dry the newborn while on the mother's chest. Signs of respiratory distress include retractions, grunting, nasal flaring, and circumoral cyanosis. Just to know what that is, it's when only your mouth or lips turn blue. There is a video within this unit module that I think it's at 37 seconds. I wrote it in the notes. It's a good example of what grunting sounds like in a newborn. This is a great image over here. You don't need to know this, but there are different types of retractions based off of where you're seeing them within the newborn. So sometimes when a newborn has retractions, it could be just subcostal. So that's really pulling the skin in towards the bottom of the rib cage here, or intercostal, where it's getting pulled in between the rib cages. Not something you gotta know, but just interesting to know that there's different portions that can have retractions. Initial cord care. The umbilical cord is initially clamped and then cut. Delayed cord clamping is common practice unless the newborn shows signs and symptoms of immediate care. The cord is always assessed for the correct vessels. So as I mentioned earlier, there's 2 arteries in one vein. The arteries carry deoxygenated blood from fetal circulation to the placenta, and the vein carries oxygenated blood to the fetus. The clamp typically remains in place for 24 hours until dry. Please educate your patients. Don't pick at it. Don't put anything on it. Sometimes it falls off within a few days. Sometimes it can take up to a few weeks. Proper identification. Infant abduction is a threat that all healthcare organizations face. Newborns are identified with wristbands immediately following delivery. They're placed on the mother and their support person, as well as the matching ID numbers as the newborn. Hospitals have placed other security measures as well. Newborns should have a band on their wrist and on their foot, and then typically on the opposite foot there's some type of a security band. A great example: if the NICU or pediatrician is summoned to a delivery room where a newborn infant has been delivered, and the newborn needs to be moved to a special care nursery because, the 5-minute APGAR is a 2. A good priority would be to apply ID bands, not trim the cord, not allow for more bonding, and not apply erythromycin or whatever medications. In this case, being taken from the mother means ID needs to be maintained. So don't ever take a newborn away unless there's an ID on the baby. Newborn medications. Vitamin K. Newborns are born deficient of vitamin K. It can take up to a week for them to produce a sufficient amount. Vitamin K is a fat-soluble vitamin that promotes blood clotting. Without supplemental vitamin K, newborns are at an increased risk for bleeding. Oftentimes, a waiver is required if the parents refuse this medication. Regarding administration, you need to give this within 1 to 2 hours after birth. An IM injection is given at a 90-degree angle into the vastus lattice of the muscle. Hold the leg firmly and inject the medication slowly. Assess for bleeding at the injection site after administration. Note: no circumcisions are allowed if the parents opt to decline this. And also make sure they fill out that waiver. So it's typically called a declination form. Why? Because of their risk for bleeding. Another side note: PO forms of vitamin K is not more beneficial. I have seen an influx in this. Research has shown that newborns cannot absorb the oral form very well, so it doesn't work well to prevent vitamin K deficiency. A vitamin K shot is the safest and best option for all newborns. This is an example of what a label from a vitamin K injection could look like. Notice that it's only 0.5 milliliters, so 1 gram, very small amount. Please check out this link. This goes over the importance of vitamin K and why the injection form is much safer for a newborn in comparison to that PO version that I was talking about. Erythromycin. So newborns are at an increased risk for developing ophthalma neonatorium, a form of conjunctivitis, contracted during delivery. A dose of erythromycin ophthalmic ointment is given as a prophylaxis. Often there is a waiver if the parents refuse this medication, but regardless, such as the vitamin K, these are both standard practice. Administration. So open the eye by placing the thumb below the eye and the pointer finger above the eye. Apply the medication into the conjunctival sac from the inner canthus to the outer canthus. Do not touch the tip of the applicator to the newborn's eye. Close the eye to make sure the medication permeates, and wipe off excess ointment after 1 minute if need be. I always try to do this ointment before I do an injection. I feel like it just, you want to start with the most least invasive medication, right? Because it's not an injection, it's an eye ointment. Hepatitis B vaccine. So this is the first vaccine of immunization, scheduled for children. Newborns can become infected during delivery if the mother is hepatitis B positive. It's typically given along with the vitamin K and the erythromycin. We do need consent to be able to give this as it's a vaccine. If I do get consent, I always try to grab a friend, and I have one friend do the hepatitis B into one leg while I do the vitamin K in the other, because I just feel like it's less traumatizing for the newborn, right? So administration, give within 1 to 2 hours after birth. An IM injection is given at a 90-degree angle into the vastus latus muscle, as I mentioned earlier. This is the only spot we give injections to newborns. Hold the leg firmly and inject the medication slowly, and you want to assess for bleeding at the injection site after the administration. Parental bonding is very important during the first few hours the newborn is born. These are the golden hours. And maybe if the mother decides to breastfeed, this is the perfect opportunity to initiate that. We will discuss breastfeeding in the next few weeks, but I'm going to give you the basics as this is part of the first 2 hours of life. You want to explain to the parents what you are doing and why you're doing it. Encourage them to be independent with their newborn care and supervise and offer support as needed. It's so important for them to start trying to be independent right off the bat with your supervision, of course, because when they go home, they're not going to have you. Educate the parents on why a newborn may be crying and how to comfort them. Maybe they're hungry, maybe they have a full diaper, or maybe they have a gas pocket. Educate the parents on thermoregulation, as we mentioned a lot earlier. Support the mother in her feeding choice. Offer education. Encourage skin-to-skin immediately after delivery, if this is possible, because as I said, sometimes there could be an emergency. For mothers wishing to breastfeed, encourage breastfeeding within the first hour of life. Pulse check. Which of the following statements by the student nurse indicates an understanding of breastfeeding? Please take a moment to answer this select all that apply question. We will discuss breastfeeding more later. However, the answers here are A, B, C, and D. Parental bonding is imperative in the first few hours of birth, and breastfeeding ties into this topic, if that is the parent's feeding choice, of course. Let's now discuss the rationales behind the answer options. A. Initiating breastfeeding early, ideally within the first hour after birth, supports effective latch, stimulates milk production, and increases maternal confidence. Evidence shows early initiation is associated with higher rates of exclusive and continued breastfeeding. B. Breastfeeding stimulates the release of oxytocin, which promotes milk letdown and causes uterine contractions. These contractions help reduce postpartum bleeding and support uterine involution, making this an important teaching point for new mothers. C. Also correct. While many newborns demonstrate rooting and sucking shortly after birth, others may need time due to factors such as fatigue, medications during labor, or adjustment to extrauterine life. This statement reflects realistic expectations and supports appropriate breastfeeding education. D. Also correct. Although early skin-to-skin contact and breastfeeding are encouraged, clinical situations such as maternal or newborn instability, as well as other emergency interventions, may delay breastfeeding. Recognizing this prevents unnecessary guilt and promotes individualized care. E is not correct. Why? Breastfed newborns do not require supplemental water. Breast milk provides adequate hydration and nutrition. Giving water can interfere with feeding, increase the risk of electrolyte imbalance, as well as reduce milk intake for newborns.